It's a great pleasure to welcome Sabelile Tenza, who's the Associate Professor at Northwest University, as well as Richard Greenhill, the Principal and Founder of SmartSigma AI. Now, Professor Sabelile Tenza is a patient safety expert who is deeply passionate about improving access to quality, safe care. Her research focuses on strengthening healthcare systems and advancing patient safety across Africa and beyond. Now, Dr. Richard Greenhill, on the other hand, is a healthcare quality and AI expert. He's got more than 30 years of experience in patient safety and system improvement, and his work focuses on translating innovation into practical solutions that strengthen healthcare and strengthen healthcare delivery globally. And we're going to be talking about this incredible connection because Professor Tenza and Dr. Greenhill first connected in 2022 at the East Quark Conference in Australia. And since then, they've worked very closely together as part of the editorial team for International Journal for Quality in Healthcare. And in 2025, they co-authored a book that went on to win a Global Health Systems Award. And we're going to be talking about the future of AI in healthcare. And firstly, welcome to both of you and congratulations on the book and congratulations on winning this incredible award. And welcome to both of you.
Thank you, Aki.
It's great to be here.
We're so glad to be
So
here.
who's going to tell me whose idea was it for the book and how did the book come along? I'd love to know more about this. Who said we've got to write a book together?
Well, it's a little bit more nuanced than that. Basically, I also am a part-time professor. I was a full-time professor, so I write a lot of textbooks globally and here in the U.S. So I co-authored with another world expert this book on comparative health systems about health systems around the world. We did not have a chapter on South Africa. So I knew Professor Tenza, and I thought, what an opportunity to have South Africa represented in this book that people read around the world in classrooms, not just here in the U.S., but around the world. So she wrote a fabulous chapter that was really amazing. And the book won an award here in the United States by the National Nursing Association, which is very prestigious. So we're very happy about that. Very happy for her contribution, actually.
Well, congratulations to both of you. It's wonderful to have you. Let me start off with you, Dr. Greenhill, and talk about the healthcare systems globally that are under pressure. How much pressure are they under? And let's talk at it from a point of view of capacity to quality of care. From your experience, where are systems simply not coping fast enough or even accurately enough?
Well, again, it's great to be here. Great to be with both of you. So really the honest answer is that almost everywhere, everybody's struggling with quality of care and capacity. And so the three areas I keep coming back to rather are diagnostic accuracy and speed, care coordination, and then the cognitive load on clinicians. So on diagnostics, our patients are still waiting for days or weeks for results that could be turned around in hours. And in that gap, their conditions get worse while they're waiting. So radiology, for example, is a clear example. There simply aren't enough radiologists globally, for example, to read the volume of images being generated. Now, that's not a problem that's unique to one country. It's a worldwide shortage. And, we're going to talk about AI can help with that. And then so on the issue of coordination, healthcare is deeply fragmented, and it's really fragmented here in the U.S. So a patient moves between a community clinic and a specialist, an emergency unit, and a rehab facility, and their information that's critical to their care often doesn't follow them cleanly. So errors happen in those handoffs, and people fall through the cracks. So, but I'll say the last point is what concerns me most is clinician and burnout. Doctors and nurses are spending more time on documentation and administrative tasks than on patients. That's simply not a staffing problem. It's a systems design problem. And it's just as real in Johannesburg or Nairobi as it is in London or New York. And so artificial intelligence, which I know is the backdrop of what we're going to discuss, has really a direct role to play in all of these.
Right. Prof, let me bring you in, Prof. Tenza. If we bring this into a South African context, which is where you have your finger on the pulse and understand the situation very acutely, how do those pressures show up differently here? Where are the biggest gaps locally that you see?
So, you know that in South Africa, we have approximately 65 million population, and 80% of these people are reliant on government's services, which are under-resourced facilities. And we also know that in South Africa, we are facing a quadruple burden of disease: HIV, TB, maternal child mortality, non-communicable disease, and violence, and other inequalities that are existing. And these then lead to more shortage, in health provider shortage, and extreme high workload. And I mean, to be exact, we estimating about a doctor to patient ratio of 1 to 2,000, and a nurse to patient ratio of about 1 to almost 800 patients. And this then means less time to engage with the patient and less time to focus on the person. And I mean, to the extreme, it has got to, some of my studies found that patients had omitted tests and omitted treatment, and people start taking shortcuts on protocols. They know what needs to be done, but they have to cope with the pressure. And then that leads to some delayed diagnosis or even misdiagnosis.
Wow, that's absolutely frightening and scary. And I guess we know that, and this is not just a South African issue, as Dr. Greenhill mentioned. This is a global problem. There aren't enough doctors globally. But let me stay with this, Prof, and let me ask you this. A lot of people hear AI in healthcare, and even in business, they think, oh, it's going to be technology replacing human beings and machines replacing doctors. Now, from your perspective, what are the real problems AI is actually trying to solve, especially when it comes to patient safety and the quality of care?
Okay, so Aki, maybe let me take you to a short lesson on what quality of healthcare is. Briefly to the listeners, the Institute of Medicine identifies 6 core dimensions of healthcare quality, which then it refers to a safe, effective, patient-centered, timely, efficient, and equitable. And these 6 dimensions I've mentioned to you, they already tell you that you've got to get that care on time, and it has to be efficient. And then healthcare providers needs to make decisions on what is safe while done by AI. You get what I'm saying? And then they have to also make that decision on what only needs their hands. So then they can be able to know when an AI can be used without them being replaced. AI could be used as a visual body or to a doctor, or a second pair of eyes, taking care of tedious tasks, as Dr. Rich has mentioned, like take away doctors' focus, the things that take away doctors' focus to caring or being with the patient. Like, for example, quick review of data, fast-tracking decisions, flag warning signs, and that a doctor may have missed. So I think in my position, AI makes suggestions, doctor make decisions.
Okay, I like it. You've put it very well. So it's almost like augmenting and helping the doctor make better decisions. Now, let me bring you in to this, Dr. Greenhill, and building on that. How does AI change what's actually possible in healthcare today? Because it's really making the lives of doctors a lot easier compared to even 5 or 10 years ago. So it's helping them tremendously, isn't it?
It is, and the shift has been genuinely dramatic. And I think that people outside the field of healthcare don't fully appreciate it yet. So 10 years ago, AI in healthcare meant rules-based systems. So if a patient's vital signs crossed a threshold, an alert was triggered. That's useful, but it's limited. Now, what we have is something fundamentally different as far as capability. We have models that can find patterns across thousands of variables simultaneously in real time that no human clinician could track on their own. A concrete example is something called sepsis, early sepsis detection. So sepsis, if you're not familiar, it kills because it moves fast, and the early signs of it are very subtle. A slight change in someone's breathing or a marginal shift in their blood results. So AI models that are trained on large patient data sets can flag that risk hours before a clinician could reasonably catch it. And we already know they're really busy, right? So that's not replacing the physician. That's giving them a second set of eyes that, never gets tired. What's changed most in the last 5 years, I'd say, specifically, is the ability to use AI to reduce documentation burden on clinicians. And in things like summarizing patient histories or generating clinical notes, supporting handover processes when patients move between clinic and hospitals. So the task and things that used to consume significant portions of a clinician's day, are now being handled by, augmenting, as you mentioned. In any healthcare system operating under pressure, that time saving is not trivial. It translates directly into more time with patients. A lot of the physicians I've met here in the U.S. or in Brazil or everywhere, are concerned about, I want to practice medicine. I don't want to be doing all these other things. And so AI has great potential for that. We already see some great movement, especially in countries like here and in Brazil and other places with ambient AI, where they're using it to augment what the physicians are doing. So
That's really fascinating. Prof, in South Africa, the healthcare systems here often operate under tremendous resource constraints. We know this. Does that make AI more of a necessity than a luxury in our context?
Yeah, I wouldn't say it's luxury, but I think my first position is that there is a need for extra support in the form of technology. Indeed, there is a need for that, but best practice standards need to be set first. I think that is very important, given our context in South Africa. There is a need, a dire need for support with technology, especially in areas like rural settings, with less allocation of specialized care. My recent studies found that there is an imbalanced allocation of resources across the country, whether the hospital is tertiary or even the district hospital, they are less resourced than the tertiary hospitals, and then even worse in rural areas. And then specialists aren't there. I mean, the recent report from Ombudsman for Health found that in one of the hospitals, they couldn't have a dietitian, and patients ended up not having a diet that is under the guidance of a dietitian. That hospital was a psych hospital. So, I mean, then in such instance, an AI assistant could be useful, supporting clinical decisions, not taking decisions for doctors. And also AI, in that instance, could bring that more information that a doctor would have maybe asked somebody who is a support structure, and they could perform diagnostics tests and provide instant interpretation immediately, and then prevent the transportation to go to other facilities from rural setting, and bridge that urban-rural difference in care, which is a part of the inconsistencies that we have in the country. And it could also provide first aid education. Maybe using cell phones, this first aid education could help people in households to know what to do when there is something, so they don't end up having death on arrival in the emergency care because a patient could have been helped earlier at home. Could the families have been more informed?
Okay, very interesting. And Dr. Greenhill, from a global perspective, are the drivers different, or is it, or are we actually ultimately trying to solve the same problem in different ways? How does it differ?
It's a good question. And I would say at the core, yes, we're solving the same problems. Patient safety, as Professor Tenza mentioned early on, diagnostic accuracy, and equitable access and clinician accountability, those are universal, whether you're in Johannesburg, New York, Sao Paulo, or Sydney, right? The drivers and urgency do look different, though, depending on the context. So in well-resourced systems, a major driver is efficiency. We care a lot about that here, reducing waste, cutting unnecessary procedures, identifying high-risk patients before they become complex emergencies. There's also significant regulatory infrastructure shaping what gets approved and how it gets deployed. But here's what I find genuinely compelling about looking at contexts like South Africa or across the African continent more broadly. The constraints force better questions. When you can't assume an abundance of specialists or reliable infrastructure or expensive imaging equipment, I believe you ask, how do we build AI tools that work at the community health worker level? That's really being innovative instead of a big system that has a lot of resources. Or you might ask, how do we support diagnostics in an example where specialist access is limited? Or how do we make this work on a mobile device in a rural clinic? One of the things I've seen over the years with colleagues in Africa is you do a lot of things, especially in resource-strapped areas, with mobile devices. It's genius, right? Those solutions are built for constraint, and they often turn out to be the most transferable globally. The innovation that comes out of necessity, in my estimation, in like lower resource settings, doesn't stay there. It really helps reshape what's possible everywhere. So I would push back on any framing that positions high-income countries as the source of solutions and everyone else as recipients. The learning genuinely flows from both in both directions, and in some of the most important work in global health AI is happening right there on the continent of Africa. So that's something that I think maybe African leaders across the continent should lean into, that you have an innovation engine because being resource strapped helps you ask harder questions and more innovative questions.
Very, very interesting. That's absolutely fascinating. Prof, let me bring you in here because healthcare is a deeply human service to provide, and it's built on trust. Now, we know the ethical concerns that come into play when with technology, and especially with AI, and especially on our continent, we start introducing AI into clinical decision making. How does that impact those ethical concerns that people have?
Yes, thank you very much, Aki, for that question. You are right. The health sector environment, it's really built in trust, and you really need, that's why there is so much investment in competency and healthcare professionals trained for long. And one of the key ethical issue is ethical principle that is a key priority in healthcare. It's the duty to do no harm. So having mentioned that, and I would like to couple that with accountability. So I think honestly, the key issues that emerge from anybody who's thinking about AI is that when an AI partnership contributes to harm, then who is to blame, you see? And is it the hospital that the system that use the system? Is it the health professional who triggers the system? Or is it the system developer, you see? So those are the kind of questions that I think they are important to think along. And I mean, part of the ethical practice is also being honesty, being transparent, and allowing a person to make an informed consent before that anything is done on them. And then when you think about how are patients being informed about this, how do we get to inform patients about the diversion from consulting a doctor and only a doctor, and then consulting a doctor plus AI consultation. You see what I mean? So it's kind of that, there is that ethical challenge to say, to what extent do you disclose to the patient that my decisions are not based on only what I learned from school. I have an AI partner assisting me with information or something like that. And then to what extent will doctors be transparent? Because then we would want to believe that a doctor makes that decision, what's harmful for the patient and what's harmful for the for the person, and what makes that decision. Like I said earlier, that the AI makes suggestions, the doctor makes decisions. So and another concern is an overdependence on AI by the doctors, outsourcing thinking. In a way to say, if a doctor keeps on asking AI instead of thinking what he would do, what will happen to that doctor? Will that doctor learn more when he receives the suggestions from AI? Will the doctor be proactive to incorporate what he knows and what he's learning from AI? Or will you rather say, okay, anyway, this AI is always right. Let me just always take the AI decision, if you get what I'm saying. So
Yes.
I think there is...
No, absolutely.
There is a lot of work we want we're hoping to get into in terms of policies and guiding best practice, or to get to how do we determine best practice when AI is incorporated to care.
Very interesting. And we do know that AI can hallucinate from time to time as well. But I guess when we're doing it in healthcare, the systems and the parameters and the data sets and the machine learning is very different to a chat GPT, and how you'd use that, for example. As an example, I think healthcare is a lot more serious and it needs to be accurate and it cannot hallucinate ever. But Dr. Greenhill, from an implementation perspective, how do healthcare systems ensure that AI actually improves outcomes without introducing new risks? And to my point that I mentioned about hallucinations, how do we put those guardrails in?
Well, this is the question that should keep all of us productively concerned. So the risks are real. AI models, as you kind of alluded to, reflect the data they were trained on. So if that data underrepresents certain populations by ethnicity, geography, or gender, or socioeconomic background, the model performs worse for those groups. So in healthcare, as you alluded, worse performance isn't abstract. It's a misdiagnosis, it's harm. As Professor Tenza said, we are here to do no harm. And so this is particularly important in a context like South Africa, I would presume, where population diversity is immense, and where historically much of the clinical research and data underpinning global AI tools was generated in very different settings. So predominantly North American or European patient populations is where these models are mostly trained. So a model validated in Boston, Massachusetts, USA, may not perform the same way as in, Bloemfontein, that has to be taken seriously. So rigorous implementation means clinical validation in the specific population you're serving, not just importing an off-the-shelf tool and assuming it works. It means making sure that you have ongoing monitoring after deployment. In fact, my company, we created a framework for that because it is so dangerous. AI models drift, data drifts. Data is like a river flowing, right? It's never the same. So monitoring post-deployment is probably more important than, or as important as how you implement it. So, the governance questions do matter. So who is accountable when AI-assisted decision leads to a poor outcome? Professor Tenza said, AI helps doctors make decisions, but the point she made about de-skilling, where people overuse the technology and they lose critical thinking, is a real threat. We've seen that in other industries, and it's something that threatens us actually. So, the right question isn't for me whether AI is perfect. It's whether it's better than the current system, under what conditions and for which patients. So if it's done carefully and transparently, I think the evidence is encouraging. But I think we have to continue to tamp down the hype and really think of it as a tool. It is not a panacea. Just like if you're trying to hang a picture on your wall, you will use a hammer. You would not use a bulldozer, right? So to think in those terms, it's a tool. It's not going to solve the world's issues. And so, but I'm encouraged by the potential, but I think we just need to temper it with a little bit of, with a little bit of, reality.
Yeah, no, I hear you, and you're 100% right. And it's a great analogy that you used there. Prof, at NWU, there's such a strong focus on quality and safety, and health systems research is a big focus for you there. How is the university approaching AI in healthcare, especially in a way that is relevant to South Africa?
Thank you very much, Aki. I'm very excited and proud of Northwest University's progress. We have an Northwest University AI hub, so we are really advanced, and we are up the ladder of the maturity journey of AI adoption and getting on the go. And we launched this NW AI hub in 2025, and it really so good. The hub, it coordinates ethical, responsible, and sustainable AI. And our strategy is clear. It emphasizes human-centered approach, innovation, proactiveness, while being responsible. All right. And we have embraced AI use in an ethical way. And I love the fact that we have been formally trained. Staff and students have been formally trained. We're even encouraged by, if you've completed your training, you send your certificate and you get a reward for having completed your training. So we've really been encouraged to make sure we know what we need to do. And most importantly, our policies take consideration of the national level existing policies like POPI Act and all that. So everything is incorporated. And the policies are clear. I've also specialized in health policy, so I know if you want a policy to be used, it has to be short and straightforward. So our policies are very good. Anybody, any student and staff can use them. And having said that, my research office has a very good niche in incorporating AI research on patients. And most importantly, what we are doing, our current projects are focused on unveiling the stance of the public. So we have projects with postgrad students who are looking into what is the adoption of the public, what is the stance, what do they think, because the journey goes via consent of the patient. And we want to know if they are ready, if they can be able to, will it be acceptable? It's just something that it's that strange. So we are looking into how can we advocate for inclusion of the public on decisions as we adopt or partner with AI. How can we amplify their voices, and how can we enhance both their inclusion, but also to get them to see what will they need to see if they would be able to understand that this is advancement of technology. It is for the benefit of their care.
Wonderful. Look, what you're both saying is absolutely fascinating, and it's a new way of looking at healthcare, and in fact, every industry has been impacted. But I think the critical part here is that they need to be the future skills need to be addressed as well. And I think that we all need to approach this with enhancing our skills and how we deal with AI. So let me start with you, Dr. Greenhill. For someone looking at the future of healthcare globally, what kinds of skills or mindsets are going to matter most as AI becomes more embedded? It's a tsunami. It's heading towards us. We just cannot ignore it. It's going to be part of the system. So how do we need to shift our mindsets? Should there be AI in the curriculum of becoming a medical professional going into the future? What is your take on this?
Well, yes, I think that is true. I would take it a level up and say that I put adaptability at the top. Again, AI is a tool, just like Six Sigma is a tool, just like a hammer is a tool, right? So I think the specific tools will continue to change. I mean, 5 years from now, it'll be something new, or maybe even a year from now. So the clinician or health professional who can ask good questions of a system because they're adaptable and are able to interpret those outputs critically and know when to override it, that person is going to be valuable regardless of what the technology looks like in 5 or 10 years. So beyond that, I think the most important emerging competency is what I would call informed skepticism, not blanket trust of AI, but the ability to interrogate it, to ask, where was this trained? Who was represented in the data? Has this been validated in my country's health system area context with my patient population? That's a genuine clinical skill that health education systems globally are still catching up to. We also need people who can work across disciplines, who understand both the clinical reality and the data and technology side well enough to be able to translate between them. Not everyone needs to build models for AI, but we do need people who can ask the right question of the people that do build them, right? And who can communicate what the technology is actually doing to patients as well as to policymakers. And then last, perhaps, and most importantly, we need people who care deeply about equity. AI can reduce healthcare disparities, or it can entrench and amplify them, which, determines, I would say which direction it goes really depends entirely on the choices made during the design of the AI, training of the models, deployment, and its governance. And so those are not purely technical choices. They're leadership, right? And they're political choices and they're ethical choices. And so the people who understand both the technology and the human stakes of those decisions are really going to be essential.
And Prof. Tenza, for students here in South Africa who are perhaps watching this, who are interested in this particular space that we're talking about, what should they be thinking about, combining whether it's healthcare, whether it's data, policy, or technology? And it's a bit of everything, isn't it? But what should they be thinking? How should they be approaching this?
Oh, I'm going to be so biased in this response. You see, I would love it if healthcare technology is invented by individuals who have practiced as health professionals because they know the struggle on the ground. And I would then, it is such a common experience that the frontline healthcare providers, they are often consulted later, even by the procurement departments when they buy anything in the industry. And when those things are bought in the facilities, they are found by these frontline healthcare providers that they are not good quality. And there's been such less inclusion of healthcare providers and frontline leaders on these decisions. So from our Northwest University Faculty of Health Science, I would really love to see more of our graduates taking a turn, going to develop and these robots that are going to close the gap, because at least they would be able to monitor is this robot able to incorporate the things we want to see, and are we not losing ourselves here and losing the heartbeat of care, which is that spirit of Ubuntu, being present and being able to be there with the patient. So yes, I would really like to see our graduates maybe someone having started with a healthcare professional chain. I'm not saying that is a way, and I declared that I will be biased, but I think that it is very important that someone who knows the needs in the ground is the one who's able to get us what is needed the most, especially in the South African context.
Wow, what a fascinating conversation. It's something I'm very passionate about. And in fact, I can talk to you guys about, for hours on this particular topic. And it's something that is certainly going to evolve. And it's very much part of our lives, technology. It's evolving the healthcare industry. It's making the healthcare industry a better place. And at the end of the day, if we can provide better healthcare to people, that's a win for all of us. And at the same time, giving the doctors the tools to be able to provide better healthcare is just as important. So it's a topic that I'm sure we're going to have another discussion about in the near future because it's evolving so fast. But I want to thank you both, Professor Sabelile Tenza, Associate Professor at Northwest University, Dr. Richard Greenhill, who joins us from the US, who is the principal and founder of SmartSigma AI. I thank you both for joining me and sharing your insights into this very important conversation.
Thank you
Pleasure
so
to be here
much.
today.
Thank you, Aki. I think we definitely need to have another session. And one important point mentioned by Dr. Richard is that we wouldn't want to use AI trained, the robots trained elsewhere for a different context. So that alone, it tells you how much we need to be up in arms and get our own Africa region robots trained.
Exactly.